A lot of our patients in an ideal world would be able to be maintained on immunotherapy alone, but a lot of times they have seasonal flares. Sometimes they need a low dose of, say, cyclosporine long term to keep them comfortable. But it's really this balancing act to see, what improves their quality of life and maintains them for the long term, especially because in particular atopic dermatitis, these cases tend to get worse as they get older.
Hi, everyone, and welcome back to another great episode. This one sponsored by DECRA and featuring dermatologist extraordinaire Dr. Jackie Watson. She joined me to talk about managing chronic allergies, something we all see in practice. And let's be honest, allergy management is tough on a good day. And then there are those cases that really test our abilities and perhaps our willpower as well. Dr. Watson walked me through how cyclosporine can make a big difference in some of these tougher cases, and I've got to say, this conversation was a real light bulb moment for me. There is nothing more frustrating than putting together what feels like this great plan to tackle red, itchy skin, only to have it completely fail to provide any sort of adequate relief to our poor itchy patients. And Dr. Watson did a fantastic job explaining how cyclosporine can really be the key in some of these cases to bringing relief to these patients and, of course, peace of mind to their owners, too. This episode is packed with helpful information and practical tips for handling even the most stubborn derm cases. So let me tell you a little bit more about Dr. Watson, and let's dive into the role of cyclosporine in allergy management. Dr. Jackie Watson is originally from Newtown, Pennsylvania. She attended James Madison University in Harrisonburg, Virginia for her undergraduate studies and earned her bachelor's degree in biology with a pre-veterinary concentration in 2004. She went on to earn her DVM degree from the University of Minnesota College of Veterinary Medicine in 2008. After earning her DVM, Dr. Watson completed a one-year rotating internship at Red Bank Veterinary Hospital in Tinton Falls, New Jersey, before being accepted into a dermatology residency program at the University of Tennessee College of Veterinary Medicine. Dr. Watson attained diplomate status with the American College of Veterinary Dermatology in 2013. As a board-certified veterinary dermatologist, Dr. Watson has practiced in New Jersey, Pennsylvania, and most recently, South Carolina. She lectures and teaches widely in the U.S. and has published in veterinary medical journals on many topics related to veterinary dermatology. Dr. Watson joined the Animal Dermatology Clinic in Greenville, South Carolina in 2022, and her clinical interests include allergic skin disease, autoimmune skin disease, and feline dermatologic conditions. She was a fantastic guest, full of tons of helpful information that I know I can take back and apply clinically. I can already think of several cases where this might be a benefit. So let's go ahead and jump into it.
Pet parents are looking for a veterinary practitioner who can prove they understand and support the relationship they have with their pet, show you value your client's trust, and earn an official Human-Animal Bond certification from NAVC and HABRI, the Human-Animal Bond Research Institute. This certification, appropriate for all members of the healthcare team, explores the scientific benefits for veterinary staff, owners, and animals, and discusses how to establish and promote a strong human-animal bond. Enroll today at vetfolio.com.
Well, for this episode, I'm excited. I'm joined by Dr. Jackie Watson, and we're going to talk about cyclosporine, which I'm a little bit embarrassed to admit. Sometimes it's just like not in the forefront of my mind to reach for cyclosporine, and I think there's some reasons for that. And I'm so glad that we kind of had our conversation beforehand to talk about this being a really effective and useful drug in practice. So, Jackie, thank you so much for joining me on the podcast. I've been really looking forward to this conversation.
Absolutely. Thank you for having me.
When I was thinking about it, when we first kind of broached this topic, one of the things we talked about was using things like Apoquel and Cytopoint and some of these other medications that we'll use when it comes to itch and atopic dermatitis and things like that in practice. But I'd love to hear your take on kind of our approach when we're using those types of drugs versus cyclosporine.
Absolutely. This is such a great topic because dermatology, treating dermatologic disease is such an art. And it's so wonderful that now we have lots of tools in our toolbox. Back when I was a resident, I did not have Apoquel, I did not have Cytopoint. So we were getting really creative. These medications are game changers. I think they're wonderful for putting out, acute fires, so to speak, with, acute itching, severe itching, things like that. But one thing I would caution the practitioners out there is to make sure you're focusing on what else is going on with the pet. Are there infections we need to treat? So, a lot of times, some of those drugs will look like they're not helping if we're not addressing secondary yeast and bacterial infections. I think they're great first line symptomatic treatments to start.
And and absolutely, like you said, they are great at putting out fires, but it can become easy to sort of say, oh, well, this works and we'll rely on this. But of course, when we're talking about allergies and things like that, these tend to be progressive, and we end up with kind of holes in our therapy here, probably because I don't know. I guess would you say, are we using these drugs more as like long-term therapeutics when maybe we should be looking at them a little bit more as those, putting out the acute fires?
I think that dermatology, especially in regard to general practitioners, is kind of going that way. We're not necessarily looking at, hey, what is causing this? Let's try to fix it right, or quote unquote, fix it right now. So I do think, they're great medications for long term, but if we're finding that they're not working as well, are we looking for underlying causes that we could address as well? I think those are more long term considerations.
Sure, sure. So I guess bringing cyclosporin into this, how is cyclosporin, when we reach for cyclosporin, how is that approach different from using some of these other medications like Apoquel and Cytopoint?
Well, I do see a different subset of patients. So a lot of times cyclosporin is actually my go-to because the patients I'm seeing have already failed kind of the more standard therapies. I do think cyclosporin should be a consideration for kind of chronic ear cases, photodermatitis cases. I do find those, bulldogs with those really swollen feet tend to not respond as well to Apoquel and Cytopoint. Those medications aren't as anti-inflammatory as cyclosporin. So definitely for the more severe cases, that's when I think we should reach for more, immunosuppressive medications.
Sure. And I know that you and I have talked before about using cyclosporin sort of in conjunction with immunotherapy. So when we take that kind of targeted approach, what are we doing there with the immune system to address the underlying allergy?
Great question. So the cyclosporin, once again, is suppressing the immune system. It's our T cell inhibitor, and then the immunotherapy is more kind of helping the patient be able to target those allergens and have a more beneficial response to those things. And it's also anti-inflammatory, so that combination can definitely benefit the patient.
Sure. So if we're reaching for that combination, and we're having success with our treatment plan, would that kind of fall under that umbrella of addressing that underlying problem?
It does, and a lot of our patients, in a ideal world would be able to be maintained on immunotherapy alone, but a lot of times they have seasonal flares. Sometimes they need a low dose of, say, cyclosporin long term to keep them comfortable. But it's really this balancing act to see, what improves their quality of life and maintains them for the long term, especially because in particular atopic dermatitis, these cases tend to get worse as they get older.
So thinking about that, when we talk about using these drugs to address the underlying problem, the underlying allergens. And like you said, ideally we would get away with just immunotherapy, but sometimes we need a little something extra. So when we're reaching for something like cyclosporin for long-term use, how do we approach that? I know I always have a little bit, I'm not always crystal clear on starting dosage and tapering and, what if we get some GI upset, things like that. So I guess the overall question being, how do you use cyclosporin effectively in practice?
Great question, because cyclosporin can be daunting. So I usually start at super low doses. So usually around, I would say 2.5 mg per kg per day, maybe every other day to start. I generally warn clients that the most common side effect we see is GI upset, so vomiting and diarrhea. If they see that, let us know ASAP so we can even maybe dial the dose down even more. But generally, I'll start at that half dose every other day, maybe for 5 days, then kind of go up to daily, and then see if we can go up to the recommended dose for atopy, so 5 mg per kg per day.
I'm writing this down as you're talking because I did go talk to my little malassezia patient about doing this. And so I'm working on sending him the information. So you said half dose, or kind of doing every other day dosing to start. And you do that for about 5 days. Then you go up to daily and you're gradually working them up over to
To
working
5
them
mg
up
per
to
kg.
5 mgs per kg per day. How quickly do you do that? Do you do it kind of every 5 days, or are you doing it over like 2 to 4 weeks?
I usually do it every 5 days, but I have the clients stay in pretty close communication with me, just so if there are any side effects happening, we can, adjust as needed. Sometimes we'll also, when we get to the maintenance dose, depending on where the pill sizes or capsule sizes fall, we'll actually split the dose and have them give it twice a day. So that's another option if you have a patient that's not tolerating the full dose once a day.
And isn't there something about when it comes to capsules and things, freezing the capsules?
Absolutely. That's one of the tricks up our sleeve. So I recommend freezing the capsules. It is better absorbed on an empty stomach, but we'll have them give it with food if there's some GI upset as well. Sometimes we'll add in, probiotics.
Absolutely, absolutely. And when you have them give it with food, do you just have them go ahead and give a full meal, or do you still try to like limit the amount of food they're giving and just say give it with a little snack, like as little
I,
as they can tolerate?
I recommend either. I think either is fine.
Okay, okay. So if we have to go not fasted, then just go ahead and go for that because we'd rather do that than have a GI upset case.
Absolutely.
Sure, sure. Now, one of the other tricks, quote unquote, I've heard with giving cyclosporin is giving it alongside ketoconazole. I know I've particularly heard about this when it comes to like the German Shepherds with perianal fistulas who, tend to be very large dogs and therefore very large doses, and kind of offsetting that with ketoconazole. Is that something we can do in a lot of patients?
That's absolutely something we can do, and I find it extremely useful for our malassezia cases where we're treating the yeast, but we need a stronger drug like cyclosporin. Plums recommends a about a 2.5 mg per kg to 10 mg per kg per day ketoconazole dose when combining it with cyclosporin. That's a little high for me. I try to stay around 2.5 to 5 mg per kg per day ketoconazole. And then cyclosporin, I'll use the half the recommended dose, so about 2.5 mg per kg per day. And the whole purpose of that is that ketoconazole inhibits cytochrome P450 and P glycoprotein. So it helps increase the absorption of the drug plus decrease its clearance.
And I would think if we were using like an antibiotic in combination with cyclosporin, we would worry about keeping a patient on that long term. Do we have that same kind of concern with ketoconazole? Like, do we need to stop it and start it, or can we taper it down with the cyclosporin? How do we administer that?
Great question. I don't find a lot of malassezia resistance. And in particular, we're usually combining it with topical therapy as well, which can help. Topical therapy is our friend. So I will taper it along with the cyclosporin, depending. Some of my malassezia sensitive patients that are actually allergic to their own malassezia, I'll keep them on ketoconazole long term, depending on how they're doing, potentially half dose twice a week and just monitor their lab work at least once a year.
I feel like this is so helpful because, it, like I said, it can be easy to say like, oh, if we're talking about apical or cytopine, oh, we're handling the symptoms here and, we've got our long-term plan. But there's certainly, like you said, the subset of patients that you're seeing, and I know, we're certainly seeing them out there in practice too, where we've improved quality of life. We've definitely made some headway, but we're just not quite there yet. There's one case in particular I'm thinking of that really, he's been to a dermatologist and we're doing immunotherapy. But it's one of these malassezia cases that you're talking about. And really, it wasn't something that really came to mind to say, hey, let's keep him on the ketoconazole because he does really well. And then, maybe we can help with the allergen part of that by adding in some cyclosporin. So I really think these are good considerations when, maybe we've helped the patient, but we haven't really gotten to like the quality of life we're looking for.
Exactly. And I do warn clients, dermatology is a progressive disease, it's incurable. So it's really coming up with a plan that keeps them comfortable, minimizing side effects as much as we can. I do have some patients that unfortunately fail everything and they're on low dose steroids, but if that improves their quality of life and the owner's on board with that, then, that's in the pet's best interest.
Do you ever have those with cyclosporin where they've kind of failed everything? You reach for the cyclosporin and combine the cyclosporin and the prednisone, or if they fail everything, you tend to go more so just to the prednisone?
I will combine cyclosporin and prednisone. So I think that's definitely an option. I would say if we're starting to get into the mixing of the immunosuppressants, immunomodulatory drugs, then that's when, we might want to think about referral or reach out to your local dermatologist. We're all happy to help. And then we can help guide you whether, I think this case needs to be referred. Here's some things you can try prior to referral. We're always happy to help.
I think that's really good advice to say, yeah, when we're starting to like really suppress that immune system to make sure, we're phoning a friend and we have all the whole picture there.
We're here for you.
I so appreciate that. And actually, it brings up another question I was thinking of when we were talking about how to use cyclosporin effectively. Really, when we're talking about side effects, have you had much of a problem with secondary infections when we're talking about immunosuppression?
I really haven't. I've had maybe one or two cases that had a very unusual bacterial skin infection, Burkholderia, if I'm saying it correctly. I believe there's a paper out of UPenn that describes that, and that's two of hundreds. So it's pretty uncommon. I haven't seen any Demodex cases. I have had one case with disseminated toxo. It was a canine patient, but that dog had pemphigus and was on several other immunosuppressants. So I really haven't had much in the way of secondary infections. And also along those lines, cancer is, a reported risk. I maybe had one or two lymphoma cases, but really most patients tolerate it well, and we're usually able to taper it depending on their response, which minimizes side
Absolutely.
effects.
And I think when we're getting into quality of life discussions, because that can be a risk with a lot of drugs when we're treating these types of conditions, and so many times, it's not the thing you want to jump to because of risks of things like cancer and things like that. But when we're talking about those risks, usually they're outweighed by the improvement these pets get in the quality of life. And like you said, it's not something that's happening very commonly at all.
Exactly, exactly. I usually start with our, uh, less immunosuppressive, so our apical cytopoint, and then if we need to take things up a notch, then I'm reaching for, our cyclosporin.
Absolutely. Absolutely. We talked a little bit a few minutes ago about referral and, when we need to start thinking about referral. It's probably before we get to the point where we're having to mix immunosuppressives and things like that. So I guess my question to you as a dermatologist would be, are there kind of some guidelines you have in your head of when we should really say, okay, this case probably needs to be referred? And when we do that, how do we communicate that with our clients to really make sure we're setting everybody up for success? We're setting them up for success with you to have realistic expectations, and then also setting up a good back and forth relationship amongst all of us.
Great question. So I always advocate for early referral. I would make sure we have patients on flea control. That's something really easy that we can do to start, but I do have some patients that are absolutely not on any flea control. So let's make sure they're on a good isoxazoline preventative. And if you want to tackle food allergies before referring, I think that especially in a young patient that's under a year of age, that's always super helpful. It's less common than environmental allergies, but more it's easier to rule out. So choosing, a really good hydrolyzed or novel protein diet, making sure we're not giving any treats, human foods. Remember your preventatives. Most of those are flavored, so we have to get a little creative there. And doing a good strict trial with a prescription diet, not an over-the-counter, off-brand, like a boutique brand. Doing that for a good 2 to 3 months would be fine to consider before referral. And then just say they fail a food trial or client is very motivated, then we're here for you. So I would set clients up for, it's going to sound like it's going to be an expensive first visit, but the goal is to head it off long term. So the testing can be costly, but the goal, at least my goal, is for my clients to see me once a year and for me to send them back to you for everything else, including medications. I would prefer patients to get their symptomatic therapy through their primary care veterinarians and focus finances on allergy testing and immunotherapy.
Absolutely. And I'm glad that you bring up allergy testing and immunotherapy because this is always kind of a conundrum for me of what to reach for when it comes to allergy testing because of course not necessarily like intradermal skin testing but we have blood allergy testing, serum allergy testing available to us in private practice, but it's always a head scratcher for me of do I do the serum testing? What am I looking for in the serum testing? Or do I leave that to you guys as the dermatologists? And, I've heard that really pets should probably have both the serum allergy testing and intradermal skin testing. What's your take on allergy testing?
Absolutely. So it's not wrong for a general practitioner to go ahead and do a serum test. There's a million companies out there. If you ask one dermatologist, we're probably going to have opinions about, any of them, but it's never wrong to do that, but you want your results to match what's going on with your patient. So if you have a patient that's more year round, but your serum test pops up with seasonal things, that might not quite fit. If you only have one or two minor allergens pop up, then that might not fit. So in that instance, you might want to think about referring for skin testing. It is considered the gold standard to do both skin and serum testing, but then, expense kind of gets up from there. So I leave it to the client. I offer both. I say if we pick one over the other, I prefer personally the skin test since we're, essentially testing the affected organ. I will do serum tests for I've had show dogs where they didn't want the dog shaved or a dog or cat that has heart murmur or other reasons we don't want to sedate. So that's what's great that we have, multiple options there. And then we formulate our immunotherapy, based on those results.
And just to clarify, if we're talking about food allergies, if I understand it correctly, we're not doing serum testing for food allergies. Can we do intradermal, or are we just better served if we're thinking this is a food allergic case to stick with the diet trial?
This is a wonderful question. This comes up all the time. So, really, the only valid way to test for food allergies is a strict food elimination trial. There are blood tests for food out there, but they're completely inaccurate. So, I do advise against performing those because then we have to have an awkward conversation with the owner when I say, I don't think Fluffy is allergic to fish or soy or whatever, kangaroo, something they haven't even been exposed to before. So just stick with your food elimination trial to rule out food allergies.
I'm like
And there is
picturing
no
this.
way to skin test for food either, unfortunately.
Okay. So in those cases, we're sticking with the diet trial, and I'm picturing this conversation with, Fluffy to say, no, Fluffy is indeed not allergic to kangaroo.
Exactly, exactly. There might be some more advanced blood testing coming through the pipeline, but as of now, the food elimination trial is the way to go.
Very cool, very cool. And I love that you brought up preventatives earlier because, I like to pat myself on the back and I feel like I go to food trials relatively quickly. I of course try to ease the clients in because it can be a big transition trying to take away all treats and everything like that. But I have to admit, I do sometimes slip on changing the heartworm prevention. Sometimes I'm like, it's just one thing once a month, it'll be okay. So I'm glad that you for that reminder to say, no, you really do have to look at those preventatives as well.
Absolutely. And what we'll reach for is ProHeart or Advantage Multi for our heartworm prevention. And then for flea and tick, Bravecto is the oral form is hydrolyzed. So I will allow that. They have a topical form, Seresto collar. So we have a lot of options there. And even considering, our joint supplements. So, Ficox HA is another one that's hydrolyzed. So you can find options for them. And as for treats, I know clients are very particular about their treats. I always try to, depending on the client, I try to tell them, you can give the kibble as a treat. Most don't know. We will allow vegan marshmallows as well, but I just caution clients to make sure they don't contain xylitol.
Sure. I actually didn't know xylitol was a thing in marshmallows, so I'm glad you said that. And you said vegan marshmallows. Are marshmallows not all vegan? I feel silly asking this question.
They contain gelatin, so
Ah, okay.
yeah, just to be completely strict, because I tell clients you don't want to do this again.
Yeah.
So yeah, exactly.
Vegan marshmallows. Okay, well, I learned something because marshmallows have been one of my go-to, but that makes sense if we have like a beef allergy or something like that. Goodness, now my head is spinning about like alpha gal and all kinds of stuff. Uh, okay, all right, now I'm getting off topic. So when we're talking about, things like vegan marshmallows and things like that, you talked about a novel protein or a hydrolyzed diet. How do you tend to approach these food cases? Do you go straight to something like a hydrolyzed or a novel protein, or there's I know there's one with like an egg protein base. Do you stair step it up, or you just go full tilt into like, no, let's go hydrolyzed or novel protein? And do you have a choice of starting one over the other, or preference?
So great question. I would say most of the time when patients get to me, they've tried almost every protein under the sun because they're all available almost over the counter. So I am reaching for hydrolyzed diets, and I'm trying to reach for protein sources that are not common allergens, such as chicken. So my go-to is Royal Canin Ultimino if they'll eat it, because that one, to my knowledge, has the smallest protein size on the market. If I need a canned version, then I'll maybe go with Royal Canin HP. There's some other companies out there, such as Rain, that have, kangaroo rabbit based diet. I think they have a bug diet now.
Awesome.
So we have a lot of options there, but just because of the subset of patients I see, I tend to reach for the hydrolyzed.
Sure, sure. Do you think some of the other, because I think they're non-prescription, like Derm Complete and things like that. Do you think those also have a role in managing these cases, or just stay away from those when we get to some of these more severe cases? I guess when I guess the overarching question, now that it's kind of forming in my brain here, is when we have some of these more severe cases, if we're looking at like an atopic dermatitis and we're thinking this is primarily environmental, should we still be keeping them on, a hypoallergenic diet of some form, or will that probably not make a difference if the problem is mainly environmental?
That's a great question. So I would say they don't necessarily need to be on a test diet, such as like Royal Canin Ultimino if we've ruled out food allergy. But you brought up Hill's Derm Complete. I actually love that diet for my atopics because it has a lot of ingredients like fish oils and things that are really good for the skin barrier. So if the clients want a high quality, and that is a prescription food to my knowledge, and my own personal hairless dog is on it. I will reach for that because it's only going to help.
Sure, sure. So that's actually really helpful because I always wonder that when I have these really bad cases, I'm like, I don't think it's a food allergy, but gosh, like, do I still keep them on this diet or not? So yeah, Derm Complete certainly, and I think there's certainly a few others out there that can be, just skin friendly.
Exactly. I think Royal Canin, or yeah, Royal Canin has Skin Topic, I believe.
Ah, okay. That's
So,
right. That's right. They
mhm.
do.
So I think those are
Yeah.
great options because once again, as we said before, allergies, in particular, atopy gets worse with age. So all the tools we can use to avoid things like steroids, is a game changer.
Absolutely. And you brought up fish oil. What about supplement wise? I love that you brought up Ficox HA. I just learned about that supplement recently and got very excited because I felt like, it was joint supplements were just not doable for some of my food allergic patients in particular. So I love the idea of Ficox HA when we're talking about like arthritis. But what about some other supplements to maybe help support the skin?
So there's plenty out there. The ones that I tend to reach for are actually Decra products. So Retinol is one of my favorites. It's a mast cell stabilizer and helps support the skin barrier. I use it in my hairless dog as well, but it's just another tool that you can add in. And I think it helps. And I do love that there's an option for cats because we don't have a lot of options for allergy management in kitties. So I'm so happy there's an option there. Another Decra product, Atopivet, is wonderful. It's another skin barrier protectant. And what I love is that it comes in multiple forms. So there's a mousse, there's a collar, there's a spot on. So for there's multiple options depending on what the client can do. Some clients don't like collars, so the mousse is a great option. I actually use the mousse in my hairless dog as well, and it actually makes he doesn't have a coat, his skin look beautiful. So it's just so nice having all these other options where, God, 10 years ago when I was, fresh out of residency, we didn't have these options.
Yes, I have a really severe allergic one on Atopivet mousse, and yeah, it does great for him. Which I mean, we're generally talking like skin barrier type of ingredients, right? Like ceramides and are we talking like HA and stuff like that?
Exactly, exactly. So all those things because dog skin, they absorb the allergens through their skin. It's been proven that atopic patients, their skin barrier is abnormal, it's thin, the allergens can more easily get through, more easily get secondary skin infections. So anything we can do to improve that for them is a game changer.
Sounds like what my dermatologist tells me. Like we've touched on a couple times here, this this is progressive, and it can be quite challenging to manage when we're talking about different allergies, atopic dermatitis, food allergies, things like that. Clients sometimes, I think, at least in my experience, have to be kind of eased into the fact that this is a lifelong condition that we're going to manage off and on, which actually makes me really enjoy managing these cases because you get the right client and the right patient. There's a lot of communication, and it's this really beautiful teamwork that improves the patient's quality of life. But I'm wondering, especially considering you do see some of these that have failed the more simple plans and are more severe. Do you have any tips for client communication and really helping clients understand the back and forth that can come with managing dermatology cases?
Exactly. I always warn clients, as you said, this is a lifelong progressive disease that's going to require one, if not multiple medications to control long term. We need to stay in close communication. So whether they're emailing, calling, coming in for brief rechecks, just say a GP is having a really busy day. I say, hey, have your client drop the patient off. You can do cytologies and things, throughout your day. Instead of just, putting through some Apoquil or antibiotics, put your eyes on those patients. But I generally tell clients that we're going to have to come up with a flare plan and a long-term plan. So flare plans being, an Apoquil or a Cytopoint, a few times a year. Um, Long-term plans would be like low-dose cyclosporin, immunotherapy, things like that. But not every treatment plan is going to work for every patient. So we just need to, once again, stay in close communication. Um, Bother me, please. Don't let things go a year. And then I find out, things have not gone very well. We see this all the time. So I caution my clients to always reach out, and we're happy to help. Even I love working with our general practitioners. I'm happy for them to reach out and ask questions. And especially if we have clients coming from like 3, 4 hours away and it's not ideal for them to just pop in for a quick peek.
Absolutely. And I love that you brought up cytologies. This is another area where sometimes I should probably be doing more more of these cytologies if I'm being honest with myself. So of course ear cytologies. I also in one of my patients I'm thinking of in this conversation learned with some of these like onychomycosis of having to really get like in the nail bed to get some of that goo out to find the yeast as opposed to just on the skin there. Can you give us some tips for when, how often, where we should be getting these samples from, and maybe like techniques? Do you like tape? Do you like swabs? Like how do you approach these cytologies? Just I won't hold you to it. More of like overarching.
Great question. Usually, for most of my standard cases that have papules, pustules and things, tape cytology is just fine. Pustules, you can actually prick with a needle and do an impression smear and look for your cocci, your inflammatory cells. I'm glad you brought up the nail bed infection. So what I'll do is I'll snap like a cotton swab and use the wood to kind of scrape out that shmoo, that nail bed shmoo, and then spread that on the slide. Scalpel blade you could also use as well. Ear cytology, I think, is also a good idea. Instead of just, maybe packing the ear, let's know exactly what's going on cytology wise. Because I've had cases where I've treated just, rods and they come in back in 2 weeks and now they have yeast. So cytology is super, super important.
Absolutely, absolutely. I think that's such a good reminder to make sure that we're looking and we're trying to find out what's there, and we're being targeted because, like you mentioned in the very beginning of our conversation here, we can control the itch and inflammation all we want, but if we're not addressing the secondary infection, we're probably not going to be very successful.
Exactly. And don't forget about your cultures too. So if you're having patients that have not responded to kind of one or two rounds of first line antibiotics, that's when you want to start reaching for your cultures to rule out resistant staph infections.
Ooh, okay. Next question with cultures and oral antibiotics versus topical. Like, I love the idea that we can touch the skin, and so we can put the antimicrobials, the antifungals on the skin. Do you have a rule of thumb for oral antibiotic versus topical?
That's a great question. That's also part of the art of dermatology. Topicals are always our friend. And I will say that topicals work about 50% of the time. So it's never wrong to try topicals first. You can use a chlorhexidine based shampoo, such as like Myconahex or Trizclor 4, you could technically do it daily. I feel like it might be a little drying, but you could do it up to every other day. Most of my routine patients, we do it twice a week. If they're pretty extensive, so there's lesions on multiple body surfaces, that's when I'll reach for orals. Once again, I'll try one first line antibiotic, just say they don't have a major antibiotic history. Most of the time, by the time they've come to me, they've seen every antibiotic under the sun. So I'm advocating for a culture. It's never wrong to culture, but just keep in mind it's an expensive test, so we want to use it appropriately.
And are you culturing like from those skin lesions that you're seeing? If we have like inguinal papules or something like that, are you getting in that inguinal area? Or is there a certain type of lesion we should be looking for, a certain anatomical region where we're going to have the best chance of getting a diagnostic result?
So I really target what the lesions look like. So if we have pustules, that's our best chance at culturing a staph. So what I'll do is I'll prick one of those pustules with a needle, with a sterile needle. I'll actually, if it's more like a dry lesion, I'll actually moisten the culturette with sterile saline, and then I'll rub it like all over that pustule, pick multiple lesions because that's our best chance at getting an answer. If we have a more crusted lesion, I'll actually lift that up with the needle and kind of swab underneath it. Same thing with a collarette. I'll lift up the edge of it and use the swab and swab underneath it. There's always an option to do deep tissue cultures as well, but I reserve that more for like deep infections. So I think for a standard superficial pyoderma, you can just use a swab on the superficial lesions.
That is really helpful. And I'm going to refrain because now my brain is like, and when do we think biopsy? And when we do a biopsy, where do we pull it from and how do we maintain that tissue? And, dermatohistopathology and all of these things. But I think that will take us pretty much into an entire next podcast episode. So I'm going to restrain myself here. Jackie, I'm so excited about how much we covered here in such a short time. I know I walked away with a ton of ideas and useful information for my patients. So thank you so much for all of the amazing information. Is there anything else you want to share?
One last parting comment I would make is that actually it's very interesting that dermatology is one of the lowest referred to specialties when it's one of the most common, one of the more common conditions seen in our pets. So basically, we're here for you. I understand, patients. Clients have certain budgets. We're happy to work with any budget. Early referral is always in the patient's best interest. Instead of seeing young patients between 1 and 3. Now we're kind of seeing patients that are like 10 to 12, where, standard therapies are definitely not helping and we have to get really creative. So once again, if we can see them earlier, get them on a plan, they see you for all their other standard things and medications, that's really in the patient's best interest. It has been shown that actually if the skin problem isn't fixed in which we know we're not fixing them essentially, but within 3 to 4 visits with a general practitioner, they're maybe going to leave and seek out a different general practitioner. So and it's been shown that that is less likely with early referral to a specialist. And even just reach out to us and we can help guide you. We're happy to help.
Absolutely. And I think even if we have a client maybe who's not quite ready to refer something, them knowing that we are in contact with you as dermatologists saying, we're getting the guidance and maybe even that helping us with effective communication there, because I think that echoes kind of what I've seen. We've all seen the Facebook post that's like, can anyone recommend a vet because my dog is so itchy and my vet can't fix it and everything. So, to your point, talking about early referral and really getting on this aggressively from the beginning, so we're not having to get into really creative therapy plans 10 years down the road.
Exactly. And one of the things I hear is I just wish my vet referred me sooner. I didn't
Sure.
know there were dermatologists. So just keep us in mind for your really severe cases, your cases where you're reaching for multiple drugs. And once again, we're here for you.
Absolutely. Absolutely. Well, Jackie, this has been such a great conversation. I learned so much. Thank you again for joining me.
Absolutely. Thank you for having me.
Thank you to everyone who tuned into this episode. Thank you to Dr. Watson for joining me. What a great conversation. And a huge thank you to Decra for making this episode possible. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. It helps other veterinary professionals like you find this and other great content we try to put out there. If you enjoyed this episode and would like to hear more, click on the Education tab on the Vetfolio website or find us wherever you get your podcasts. We're always eager to hear your thoughts and ideas for future episodes. Feel free to reach out to me at dvm@vetfolio.com, connect on Facebook at Dr. Cassie DVM, or follow me on Instagram at dr.cassie, CASSI.dvm. And remember, if one animal is better off because of you today, it's a great day.